This program is supported by an educational grant from Cadence Pharmaceuticals.
You're watching VHA TV, the award-winning satellite network of VHA. This program is confidential. Duplication of this program without permission of VHA is prohibited, except for use by participating healthcare organizations.
The importance of perioperative pain management has been repeatedly demonstrated in recent years. Adequate perioperative management of pain can reduce the patient's length of stay and decrease post-operative complications. However, approximately 75% of surgical patients continue to report moderate to severe pain after surgery, which can result in higher morbidity and mortality. Delivery of adequate pain control during the perioperative period is the responsibility of the practitioners involved and may be achieved using existing drugs and techniques. Welcome everyone, I'm Beth Wilson. This program will review current analgesic modalities and identify challenges to providing perioperative analgesia following a variety of surgical procedures. Joining me for this program are three distinguished panelists. Deborah Wagner is Associate Professor of Pharmacy Anesthesiology at the University of Michigan Hospitals and Health Centers in Ann Arbor, Michigan. Eugene Viscusi is Director of Acute Pain Management and Associate Professor at Jefferson University in Philadelphia, Pennsylvania. And Tong Joo Gan is Professor of Anesthesiology and Vice Chairman of Clinical Research at Duke University Medical Center in Durham, North Carolina. Welcome to all of you. We're so glad that you're here.
Thanks.
All right. Well, before we begin our presentation, please keep in mind that this program is interactive. And at the end of the program, we'll open the phone lines to take your calls. The toll-free number is 1-800-565-8107. Or you can send us your questions in an email to vhatvlive@vha.com. And for those of you viewing this program as a live website, at any time you can type a question or a comment and with a click of a button, send us your message. And one more detail. We created a handout of the slides presented for this program. The handout is a good reference, and from time to time we may refer you to a specific page. It is also an excellent resource to study after the broadcast. All right, Gene, let's begin with you. Can you kind of give us an overview of what we'll be talking about today in terms of pain management?
Certainly, Beth. Just putting the problem right on the table in postoperative pain management, 80% of patients still report pain after surgery. 4 out of 5 patients report moderate to severe pain, and even though patients may not mention it, pain is still the primary concern of most patients prior to surgery. I have a study that I'd like to present. This is Coley's retrospective data review of nearly 21,000 patients who had same-day procedures in a 12-month period. The researchers looked at 30-day follow-up on all of these patients and identified anybody who returned for any reason. Surprisingly, the results showed that a third of the readmissions were due solely to pain. 5.7% of patients returned to the hospital within 30 days. What's very concerning is that these unanticipated admissions and readmissions cost almost $2,000 per patient. So it's a huge impact economically and a very important humanistic concern, and the vast majority are potentially preventable with proper pain management. Now, there are 2 studies that I think are very important, and we have those in the graphics, and I've taken the studies and juxtaposed the data so that you can see side by side some very interesting findings. The first is Carol Warfield's study that was presented in the early 1990s, and this was a survey of patients, outpatients' experience with pain, and you can see that the majority of patients suffered moderate to severe pain. The second study is Jeff Affelbaum's study, almost 10 years later in the early 2000s. The data is virtually unchanged. There still is this tremendous burden of pain on patients. What I find very concerning with these data is that this is the decade of pain. We had the Joint Commission statement on pain management. We had the American Society, acute pain guidelines, other guidelines. So even with all this attention that was focused on pain management, we still have these gaps. It raises the question, why?
All right, thank you, Gene. You know, Deb, we're all familiar with pain. I mean, everybody has had pain at some point in their life. But what is the clinical definition of pain?
Well, Beth, the International Association for the Study of Pain has defined pain as an unpleasant sensory and emotional experience associated with either actual or potential tissue damage or described in terms of such damage. I would say why perioperative pain management? Because it's the right thing to do. We know oftentimes the perception is that pain is an acceptable part of surgery, but why? We have a lack of established acute pain services in many institutions. Patients don't receive adequate counseling about expectations of pain that they may have. And there's a transition of care issue with that we know that 40% of patients still have pain 24 hours after discharge from a hospital setting.
Amazing. Deb, what are some of the physiologic effects of untreated pain?
Well, pain affects almost every organ system. We are really concerned about respiratory effects because we have increased skeletal muscle tension, and we know that pulmonary dysfunction is a major cause of morbidity and mortality in patients. We can have increased heart rate, neurohormonal changes such as increased hyperglycemia or increased lipolysis that occurs, GI effects, genital urinary effects. I think key is we have changes that occur in the immune system and also hypercoagulability, and then cognitive dysfunction occurs in probably 10 to 50% of patients, at least on a short-term basis.
What are some of the consequences then of uncontrolled pain?
What we really worry about is the long-term chronic pain that is often incurred by the use of opiates because they reinforce nociceptive memory. We also have sensitization that occurs so that receptors still send signals of pain even after the stimulus has been had. And then this often can lead to, as we know, delayed discharge from our recovery units and recovery areas that can increase cost to our institutions, as well as a decrease in patient satisfaction. So what is the body's response to a painful stimulation? As you can see in the diagram in the handout, once a stimulation occurs to the skin, damaged cells now release a stimulus of chemical mediators. These can be serotonin, prostaglandins, bradykinins, substance P. These all cause inflammation at the site and serve as a protective mechanism for the body. If we look more closely at the pain pathway, we can see there are 4 things that have to happen. We can have transduction first, the interpretation of the pain at the site, but that has to be transmitted through the spinal cord to the central nervous system. Once that happens, patients have to perceive what the type of pain is, and then some sort of modulation and negative feedback happens such that other inhibitors take place that can help relieve the pain. As you can see here, each of these pathways we can modify by using drugs to affect each of the points in that whole process.
Deb, what is it meant by when you talk about the impact of incisional injury?
Well, we worry about plasticity, active dependent, that occurs, meaning that we have an increased or heightened sense of the responsiveness to pain. And also hyperalgesia can occur, both primary and secondary. That means that we have a heightened sense of the pain. It can be either at the site where the injury or the incision was, or it can be in surrounding tissues around that area. And lastly, what we are doing more of is this quantitative sensory testing, and what that helps us do is to quantify the nervous system's input-response relationship to the pain sensation, so that hopefully we have a better handle on that.
What is Prospect?
Prospect. Prospect is an evidence-based procedure-specific postoperative pain management strategy. This was a group of surgeons and anesthesiologists who got together and wanted to review all of the randomized clinical trials. And what they found was that analgesic efficacy varies dramatically between the different types of surgeries that we see. As all of us know, there are very different differences that exist in analgesia between agents. We oftentimes forget that a percent decrement in the amount of pain is relative, because a decrease from, say, 100% to 50 may be different than 20 to 10. So what is really more important? And then we have to evaluate the side effects of agents that we use. So, for instance, we wouldn't want to use an antiplatelet type of drug in a patient who may have bleeding complications postoperatively.
In a fairly recent and somewhat controversial clinic concept is that of preemptive analgesia. What is preemptive analgesia, and what's the problem there?
Right, preemptive analgesia. Well, ideally, what we would really like to do is to reduce the central stimulation throughout the entire postoperative period. We would like to not just prevent pain, but we would like to be preemptive, be ahead of the pain, and make sure that we give the patient comfort beyond the actual surgical procedure that's being done. One of the issues that we have, though, right now currently, is that we are not sure exactly which medications work best together, what doses are the appropriate doses to give. When should the drug be administered? Should it be given, say, before the surgical incision or before the patient perceives pain happening to them?
And you have an acute pain summit that you have mentioned. Why don't you talk about that as well?
Yes. In 2005, the Acute Pain Summit set out to evaluate 10 practice-based statements, basically to compare what people perceive, their perceptions of pain management, to what really does the evidence tell us, because often there's a disconnect there. Two that I'd like to focus on. One is Statement 3, which stated the use of multimodal analgesia improves postoperative pain control and reduces analgesic-related adverse effects. What they found when they looked at the data was this was categorized as 1A, the strongest level of support for analgesia, also being level A, being good evidence to support, whereas side effects were level E, which meant that the evidence was actually very poor. Statement 7 was that poorly controlled postoperative pain leads to an increased likelihood of chronic pain. I think this is very important. And here the evidence was categorized as level 2, also very strong, and the level of support, level A, meaning that it was supportive of that concept.
All right. So what should a multimodal plan include?
Well, the goal of a multimodal plan is to achieve sufficient analgesia by attacking all portions of the pain pathway. We can enhance or achieve analgesia with additive or synergistic effects by using different drugs together. Hopefully, what we'd really like to do is reduce some of the doses of drugs we're using to minimize side effects that patients may have. And we want to really go after attacking individual different portions of the pain pathway. That's really the concept of multimodal therapy.
All right. What does the literature tell us?
Well, the literature can be conflicting. Moinchi et al. Had a meta-analysis of 80 studies using identical analgesics and techniques, and came to a negative conclusion that there was no value or benefit of either giving pre-op versus post-op analgesics. This was in contrast to Ong, who looked at an additional 10 studies, and he found clearly that there was a profound effect of epidural analgesia, local anesthetics, and systemic NSAIDs that showed a reduction from 55 to 45% in the use of supplemental opioids.
Deb, tell us, what are some patient-specific challenges?
Well, that's a really interesting topic. We forget, we always tend to treat the mean, and we have the ends of the curve. Pediatrics, in particular, of interest to me, is that people often don't know the appropriate tool to use for pediatric pain assessment. There's a concern for adverse effects in children, and also a fear of addiction and tolerance that can occur. We also know in geriatrics, with our aging population that we see, that there are altered physiological responses that can occur. They have a loss of tissue compliance, and the biggest thing is a reduction in CNS mass which means that they are more susceptible to the effect of some of the analgesics that we use.
Is there surely there are predictors of analgesic consumption? What are those?
Well, there was a study that looked at a systematic review of 48 studies of 43,000 patients, and the predictors of pain intensity were interesting. They were, if patients come into your setting in the pre-op area and already have existing pain, or they're very anxious, which many patients are, that's a very strong independent predictor of post-op pain. Also their age and the type of surgery that they're going to have.
What are the predictors then of analgesic consumption?
So interesting, independent predictors were also very similar to the pain intensity that we saw. Age was a predictor, psychological distress, and the type of surgery, although in this case the surgeries were different than the surgeries that were associated with pain intensity.
And what does all of this
all of these points,
what does all of this mean? Can you summarize this? Yeah.
All of these points really try to focus on the goal of multimodal therapy, that we want to improve the recovery of patients and the function. We'd ideally like to reduce opioid consumption, and we'd really want to increase patient satisfaction.
All right. Thank you, Deb.
Thanks.
Good information there. For this broadcast, we visited each of our panelists' fine institutions to get a brief but insightful look into their pain management strategies. We began at the University of Michigan Hospital and Health Services in Ann Arbor, Michigan.
The management of adult and pediatric pain differ in a number of ways. With the adult pain population, we have the ability to assess patients directly rather than through their caregivers or family members. There's a need to have good communication with the patient, explaining to them what they're going to experience as early as possible in their care, and set expectations that they'll be experiencing.
And so we look at behaviors, and we use a pain tool that was developed and validated here at the University of Michigan called the FLAC tool. And that's a list of behaviors, and the nurses are able to observe those behaviors and then count the numbers and come up with a score from 0 to 10. Some kids actually can just use their fingers and they'll say no pain or medium pain and a lot of pain. And that works really well for kids who are in ICU that might be intubated, or kids that don't understand numbers, but a lot of kids understand small, medium, and large.
Some of the shared issues of managing a pain service involve collaborating and discussing on a daily basis the issues that arise with the children that we take care of. We have to work very closely with the surgeons and also the medical specialists who treat those patients on a daily basis to provide the best possible pain control for our patients. This involves a large group of people on the pain service, including nurses, residents, fellows, and staff physicians. And we also collaborate with psychologists and child life specialists and other specialists to help provide multidisciplinary pain control for these patients.
The value of distraction is engaging the patient in a task that allows for them to be comfortable and calm and relaxed if they're going to experience a more painful event, such as a dressing change or some other temporary event that might heighten their pain needs. This can minimize their need for additional drug therapy, can reduce the total amount of drug that they're using for that one painful event, and thereby minimize side effects that they would experience afterwards, such as excessive sleepiness or sedation or excessive nausea.
Providing the best possible experience for the patient, and a big part of that experience is how we manage their pain. How can we make that experience not be, I think of as memorable. I don't really want people to think always in terms of, oh, I remember all the pain I had. I'd rather they remember that we provided excellent nursing care for them, that we made them comfortable, and we showed that we cared about them.
All right. TJ, let's continue our discussion on pain management by turning to a very strong analgesic, opioids.
Well, Beth, opioid has been used since a historical time. It is a good analgesic. It works on specific receptors in the central nervous system, in the spinal cord, and in the brainstem. It has great efficacies. The dose is dependent, the pain relief is depending on the dose, and there is no ceiling effect. So in other words, the more dose you give, the greater the pain relief effect is. It is generally safe with regards to cardiovascular effect. It has very little effect on blood pressure or heart rate, minimal effect on liver function as well as the renal effect. It can also be delivered a variety of ways, from oral to intravenous to transdermal, epidural, spinals. So there are different ways that we can administer these agents. Common agents include morphine, hydromorphone, and some of the newer ones, fentanyl, sulfentanyl, oxycodone, and oxymorphone. Now, however, there are some side effects. Just like any good things, there are some baggages. And in fact, there are many opiate-related side effects, and the gastrointestinal is one of the more prominent ones. This systematic review analyzed some of the opiate-associated adverse effects after surgery. And what they found is that, incidence of nausea and vomiting is very common. And, patients have a lot of things to worry about after surgery, and we don't need to add more side effects problem to these patients. And the study found that more than 30% of these patients reported adverse events, most commonly nausea and vomiting. There are other side effects, for example, sedation, somnolence are very common, drowsiness, dizziness, cognitive dysfunction, as Deb talked about earlier. These are common. And in addition to that, there are some perhaps less common, but nevertheless more life-threatening side effects, respiratory depression. And these can lead to very bad outcomes in our patients. So the important objective here is really to balance between, on the one hand, effective pain management, and on the other hand, minimizing the adverse effects.
Are there any trade-offs in pain management?
Absolutely, Deb. In fact, in life, there's a lot of trade-off. We do trade-off all the time. And I think we often think effective pain control is the most important objective. But one aspect I think is underappreciated is the side effects profile from the drugs that we use. It's just like buying a car, for example. If you want to go and look at a car and, you do trade-off. So let me first of all share with you this study that we conducted in the post-surgical patients undergoing major abdominal procedures. We use an adaptive conjoint analysis in a form of interview to question patients about their preferences, trade-off between pain control and side effects. And you'll find it in your handout on page 21. And we hypothetically choose between degree of pain relief that asks patient as well as the side effects. And we talked about just like the buying a car analogy. If you want to buy a sports car, you go and look at various features. There are some of them advantages. You like the 0 to 60 miles per hour in, let's say, 4 seconds. But you don't quite like the sort of leather seat in the car. So we trade off all the time, and there's no different in pain control. And in this study, what we found is that patient was almost twice as likely to select less pain relief over increased or severe side effects, nausea, vomiting, constipation, and itchiness. And in fact, in patients that you give them PCA, patient-controlled analgesia to control their pain, they almost never titrate their pain down to zero. Why? Because they experience that if they give themselves a lot of opioids, that comes with side effects. And they do not like the side effects, just like shown in this study. So how can we improve pain while controlling some of the side effects? And the key here is to use a multimodal pain management approach. And in fact, the American Society of Anesthesiologists practice guidelines in acute pain management in the perioperative setting actually said that, and I quote here, whenever possible, anesthesiologists should employ multimodal pain management therapy. Unless contraindicated, all patients should receive a round-the-clock regimen of NSAIDs, coxips, or acetaminophen. And many think that multimodal approach is combining two drugs. But in fact, to be effective, the use of multiple drugs would further enhance analgesia, at the same time reducing the side effects from each drug.
All right, so TJ, in addition to NSAIDs, acetaminophen, and coxibs, are there any other analgesics that can be used in an adjunctive capacity?
There are, Beth. There are a number of analgesics. In fact, we consider them as analgesic adjuncts. In addition to those that you mentioned, there are local anesthetics, ketamine, gabapentin or pregabalin, the alpha-2 agonist, clonidine, dexmedetomidine, and there are also a variety of others, including nicotine, magnesium, neostigmine, adenosine, naloxone have been studied, and also some of the non-pharmacological techniques.
That being said, how does one successfully implement then a multimodal pain management strategy?
That is a very good question, and this is the practical aspect. And I'd like to share with you this multi-step approach. Now, the World Health Organizations have a ladder that built on each steps of analgesics. Similarly, in the acute setting, there are multiple levels. So, for example, at step 1, where you have mild postoperative pain, we generally use the non-opioid analgesic, including acetaminophen, non-steroidal, COX-2, local anesthetic. And beyond that to step 2, where you have moderate postoperative pain, you still use the strategy in step 1, but in addition to that, add intermittent doses of opioid. Beyond that, even more severe pain, step 1 and step 2, as we talked about, in addition to that, introduction of more strong opioids, the peripheral nerve blocks, catheters. Those are all the options that can be considered.
Does the model for multimodal analgesia offer advantages over morphine alone?
Absolutely. I think that is the key message, that evidence has shown that all these analgesics work together much better. So I'd like to show you some evidence that support that. This is a meta-analysis that looked at over 50 studies, more than 5,000 patients, that used the step 1, as we talked about, acetaminophen, non-steroidal, COX-2 inhibitors, and what these meta-analyses found was that there is a significant, over 50% reduction in morphine consumption. Half the morphine consumption, in addition to that, with a reduction in VAS pain score. The opiate-related side effects, nausea and sedation, are significantly reduced. They also find a slight increase in renal failure rate, most likely because of the non-steroidal anti-inflammatory drugs. And the results are fairly consistent. There are multiple, many studies. And one of the studies which I like to focus on is the study of using acetaminophen in total knee and total hip replacement. So in one group where you have IV acetaminophen, proparacetamol is another acetaminophen which is not FDA approved in this country. But what this study suggests that there is an overall 30% reduction in morphine use, and also the time to rescue is significantly prolonged in the acetaminophen group. Now, the next important adjunct I'd like to talk about is local anesthetic. Now, local anesthetic is, again, an important adjunct. Studies have shown that it certainly can relieve pain, but also it's important to note that, as you see on a handout in page 28 there, where the location of injection is important, and this series of studies shows that if you inject it intraperitoneally or in a fallopian tube, is more effective than port site infiltration. But in fact, the efficacy of local anesthetic is further enhanced if you use it in epidural, spinal, peripheral nerve block techniques, and you can prolong the action by using an infusion of local anesthetics and send patient home. Now, there's a new long-acting depot delivery of bupivacaine, which lasts 72 hours after a single injection. Could you imagine that? Now, ketamine is another one which I think is important to mention, and is an important adjunct, and studies have shown that not only does it enhance analgesia, but it also significantly reduces morphine requirement, as is shown on the graph here.
TJ, what are the recommendations on ketamine?
Good question. I think ketamine, depending on the type of patients, patients who are opioid naive, I typically give a single dose of 0.5 milligrams per kilo at the beginning of anesthesia. And for those who are opioid dependent, I typically prolong that by giving an infusion of 10 to 20 mics per kilo per minute, not only during the intraoperative period, but also beyond that into the postoperative period.
What about the effectiveness of gabapentin and postoperative pain?
Yes, gabapentin is interesting, and gabapentin is an old drug which has been used as anticonvulsant, but more recently gabapentin has been shown to be an effective adjunct in acute pain management. And a number of study has been done. This is a meta-analysis which you can find in your handout in page 30 that we performed a number of years ago. And what this meta-analysis demonstrates is that when gabapentin is used as a single dose of 1,200 milligrams preoperatively, significantly reduces the incidence of opiate-related side effects. You see that nausea is reduced, vomiting is reduced, pruritus. Now, it is important to note that gabapentin is a sedative, and therefore you see that there's an increased risk of sedation, although there was no difference in respiratory depression. So we need to, in fact, I'm now trying to lower the dose down to about maybe 600 milligrams. Another category I think is worth mentioning is the alpha-2 agonist, and has been successfully used. There are two drugs here I'd like to just mention, an older drugs, clonidine, which is used for treating blood pressure, and also a newer drug, which is much more specific alpha-2 agonist called dexmedetomidine. And in studies like this one that you see here has been shown to reduce not only pain score, but also opioid morphine consumption.
All right. What are other opioid adjuncts? Which ones have been used?
There are many others, and you will find that, for example, one of the things that has been commonly used is naloxone. Interestingly, naloxone typically is used for reducing side effects. And in this study, what we found was that if you use naloxone in a very small dose, the dose I'm talking about is 0.25 miles per kilo per hour or 1 miles per kilo per hour, both doses reduce opiate-related side effects. But in fact, the very low dose has been demonstrated in this study as well as the others also reduce the amount of morphine consumption, which is sort of contra to what we tend to believe as an opiate antagonist.
All right, great information, TJ. Can you just kind of summarize all of this for us?
Absolutely, we'll be delighted. So, in summary, opiate is effective, but it does come with some side effects, and some of it may be significant. And pain relief, I think, is optimal pain relief require a multimodal approach. And there are existing and new analgesics that I think can be successfully used as opioid adjuncts. The take-home message really is that multimodal pain management strategy enhances efficacy and reduces side effects.
All right, TJ, thank you very much.
Thank you.
Well, let's travel to Durham, North Carolina, and get some insight into pain management at Duke University Hospital.
I think the benefits of having an acute pain service are that we more economically and efficiently manage the pain. Duke has an advantage in having this kind of a pain team where we are on call round the clock, and that we can improvise and also provide treatment for patients right away. We have set guidelines of what we're able to do, and it involves being able to respond to the patient more quickly, to manage their pain better and more easily.
One of the ways that we optimize postoperative pain control is by utilizing regional anesthesia techniques, specifically regional anesthesia, continuous peripheral nerve catheters. These nerve catheters are placed near the nerve with ultrasound technology, preoperatively primarily.
Totally transformed my practice in the past 7 or 8 years. Ultrasound lets me see beneath the skin, look at the nerve, see which individual branch I even want to block, make sure the local anaesthetic surrounding the nerve. More important as well, making sure my needle's not touching the nerve, reducing the instance of complications, making sure my needle is not in a blood vessel, so reducing complications through intravascular absorption of local anaesthetic. So more successful, quicker to do it, less side effects. Ultrasound's really transformed regional anaesthesia.
That catheter is then attached to a pain pump, which works very well here with our pain team. In addition to that, patients are able to take home an ambulatory pain pump, which they then are able to control their pain at home for 2 to 3 days without using opiate-based medications.
We use a simple, disposable elastomeric pump. The patient goes home with the pump with instructions, and We'll phone them at home and they'll remove the catheter themselves, peel off the dressing holding the peripheral nerve catheter in place, and then the whole kit and caboodle just gets thrown in the trash.
One of the specifics that this is great for is decreasing the need for Percocet or OxyContin or oxycodone that, as any patient who's taken these pain medicines can tell you, causes nausea, vomiting, constipation, and a lot of side effects. A lot of our patients go throughout the postoperative period without the need for opiate narcotics medications at all, with only a continuous peripheral nerve catheter in place.
I've been here about 10 years, and there's always something to learn, always something to do, and a good team to be a part of.
Well, Gene, you started our presentation. It's your turn again to offer your expertise on pain management. Let's begin with an overview of some of the challenges and possible solutions with new and emerging techniques.
Thank you, Beth. Well, I think there's a term that really crystallizes a lot of the issues and problems we talked about so far. That term is analgesic gaps, namely that patients actually have pain relief for much of the time, but they'll have discrete periods during their postoperative period where the technologies fail. So the technologies we have, some of the emerging technologies work, but we have to understand what causes these gaps in order to best use the new and current technologies. So TJ talked about these opioid side effects, the nuisance, the nausea, the vomiting. If you're relying heavily on PRN opioid treatment, patients are apt to delay that next dose because they're balancing the side effect profile. The other thing we find is that generally we're not very good with dealing with the transitions between our therapies. So if we're relying heavily on that epidural or a continuous peripheral catheter, even IV-PCA, we discontinue that and leave the patient with another analgesic gap. Whereas if we had layered this with multimodal techniques, we would eliminate some of those gaps. Finally, one of the areas that's, I think, most concerning are the technology failures. Epidurals have about a 30% failure rate. IV-PCA depends on the pump, the catheter, the IV site. So there's a lot of technical issues with these current and old complex delivery systems that lead to inherent gaps.
What about improved drug delivery systems? What should we know about new and emerging techniques of getting the drugs to the patients?
Well, Beth, there's a lot of really exciting developments on the horizon, some recently approved and some drugs that are in the development profile. So one that I'd like to talk about is ionophoretic delivery. So instead of cumbersome IV-PCA with all the tubes and hoses and pumps and catheters, imagine this device that's about the size of a credit card, that it just adheres to your skin, has a little button that you could double click like a computer mouse. This concept is able to deliver small lipophilic molecules, positively charged, through the skin in a very precise fashion, very much the way IV-PCA works. So imagine if you had a needle-free device about the size of a credit card, preloaded with drug, pre-programmed to eliminate some of the medication errors. Could you find a use for this compared to standard IV-PCA? Other things on the horizon. I think single application of drugs that last a long time is really very advantageous, so we can get away from these catheters and hoses and pumps and whatnot. Liposomes are one way of delivering drugs that last a while. So one product that's currently available is the extended release epidural morphine, and in your handout you'll see some of the data from one of our studies that we published in Anesthesiology showing that a single application of this extended release epidural drug lasts a very long time. What you see in the graphics is that there are those patients that receive the epidural extended release morphine and the patients at the top line that did not. And they got fentanyl PCA as a measure of pain relief and their rescue. And what you can see is that the patients that got placebo have a consistent requirement for additional opioid. Now, I'd pause to say, this isn't a prescription that you should therefore use IV-PCA with this Depot or the extended release product. In fact, when we use this drug in a multimodal platform, we are able to virtually eliminate IV-PCA and all the catheters and hoses and just give patients additional oral rescue. So you've had your joint replacement and you have no PCA or no catheters. Another area that TJ talked at length were these nuisance opioid side effects, primarily GI. Now, much of that is due to the peripheral opioid receptors, not the central ones that cause the analgesia. So imagine if we could antagonize just those peripheral receptors. And indeed, there's 2 approved drugs that fall into this category of peripheral mu opioid receptor antagonist. Alvimipam was approved for treating postoperative ileus, which is in part due to opioids. The other drug, methylnaltrexone, is approved for the treatment of opioid-induced constipation. Interestingly, in the signal with all of these studies, if you look at the adverse event profile, there is a reduction in nausea and vomiting and these other nuisance GI side effects.
What about acetaminophen in pain management?
Well, a lot of people think of acetaminophen as plain old acetaminophen, but really it is a potent analgesic when administered around the clock. It's one of the oldest, safest drugs we have, and yet we still do not really understand the mode of action. There have been a number that have been proposed, such as a COX-2 or COX-3 pathway, a 5-HT3 serotonin pathway, even opioid receptor subunits, indirect NMDA receptor, and so on and so forth. But one of the front runners right now is that it's a cannabinoid receptor agonist, the CB1, which I think is really interesting that we're now looking at all of these other receptors that modulate pain. TJ had mentioned the IV acetaminophen study in orthopedics, and I just want to highlight that a little more. What we did in this study is we had patients who had hip or knee replacement. We allowed a washout period of the day, and then the next morning, post-op day 1, we stopped their IV PCA and waited until the patient had a significant complaint of pain. Then they received either a placebo injection or IV acetaminophen. And the results, I think, are quite interesting. When you look at the graphics in your handout, what you see is that there was a significant reduction in pain in the group that got IV acetaminophen, significantly greater patient satisfaction, a third less morphine in the group that got IV acetaminophen, and also a significant delay in the time in which they request rescue. 3 hours with IV acetaminophen versus less than an hour in the group that got placebo. And overall, the side effect profile looks similarly within the 2 groups. So it looked quite promising, and this has been replicated in a number of other IV acetaminophen studies.
So, Gene, are there newer agents then that have recently been released that look promising?
There are. One very recently approved opioid, tapentadol, is the first new opioid that's been approved in decades. And what's interesting about this opioid is that it is not only a potent mu opioid agonist, but it has this auxiliary pathway of norepinephrine reuptake inhibition, which we exploit with some other drugs in pain management. What's interesting is when you look at the studies, not only is there clearly efficacy similar to oxycodone, but there's this signal of reduced opioid side effects, less nausea, less vomiting, even less constipation across the studies. So I think that's very interesting that this dual pathway might have an impact on common side effects.
What about old drugs with new uses?
Old drugs, new ways. TJ touched on the benefits of ketamine. I don't know what I would do in my practice now without ketamine. There's a very interesting study recently published by Loftus with some of the most challenging patients. Imagine the spine surgery patients who are chronically on opioids. What do you do? So similar to TJ's protocol, a pre-incision dose and intraoperative infusion. And look at the data in your handout. What's interesting is that not only do they show improved pain relief right after surgery with less opioid consumption, but even at 6 weeks, we see this signal of less opioids and improved pain control. So now we're starting to see that these multimodal approaches have potentially a long-lasting effect on pain management. Now, I'm going to take it a step further. There's a very interesting study that Kumar Bhuvanendran published recently with the use of pregabalin in a very complex multimodal pathway, in this case with knee replacements. And basically, these were knee replacement patients who received acetaminophen, a COX-2 inhibitor, epidural anesthesia, analgesia, and then either placebo or pregabalin over a 14-day period at a pretty hefty dose, probably more than we would normally use in our clinical practice. And what he was able to demonstrate is that the patients who got pregabalin included in their multimodal protocol had a marked reduction in pain and improved movement. But further down the road, at 6 months, there was a reduction in chronic pain. What's little identified is that knee replacement patients often have neuropathic pain at about a 9% incidence following their surgery. The group that got the additional pregabalin had no neuropathic pain, whereas the other group had almost 9% at 3 months and over 5% at 6 months. So the conclusion here is that something that's done in the acute phase had a far-reaching effect, maybe a permanent reduction in chronic pain following surgery.
So, Gene, what may these new and emerging technologies lead to?
Well, if we take all of the pieces and put it together with multimodal analgesia, I think we should be able to have less reliance on opioids and make multimodal analgesia our standard, thereby reducing the common opioid side effects, nausea, vomiting, respiratory depression. Key is the reduction of these the analgesic gaps that really plague the postoperative patients. Improved dynamic pain, better mobility if we can reduce the amount of tubing and hoses. And a real goal would be the reduction in chronic pain following surgery. And then a very important point today with HCAPs and other measures is this improved patient satisfaction. It's going to drive a lot of how we do our care. And then finally, if I really had to look into my crystal ball about postoperative pain management, I would say multimodal with an emphasis on opioid reduction or even elimination really should be the goal. Less reliance on these invasive technologies with indwelling catheters and pumps and hooking the patients up to IV poles. And the emerging use of these extended release technologies where a single application of something lasts for 24, 48 hours longer to produce relief without the burdens of care that we have with our current technologies.
All right, interesting information. Thank you, Gene.
Thank you.
All right, Thomas Jefferson University Hospital takes great pride in their pain management strategies, as we discovered when we visited Philadelphia.
We're actually one of a small number of centers in the country where we're seeing most of our patients preoperatively. Some of the advantages of having a preoperative visit are the fact that the patient gets comfortable with the facility, that the patient has an opportunity to ask questions about what's going to happen to them during the time of their hospitalization, that the patient can then help provide us with information that's going to impact the quality of care that they'll receive during their admission.
One of the special and unique things that we do here at Jefferson in dealing with difficult populations is that we use sub-anesthetic ketamine infusions postoperatively, intraoperatively and postoperatively on regular nursing units.
The importance of having ketamine on a standard floor rather than a monitor setting is that patients could be on ketamine, be comfortable, and you don't have to rely on other opioids. We could cut down the amount of opioids that patients use and use ketamine on the floor in a safe setting, and as a result, patients are more comfortable on the floor.
These are the difficult and challenging pain management populations. They include the post-op chronic pain patient who's been on opioids, the drug-addicted patient who's had surgery, palliative care patients who are at end of life and on huge amount of opioids, and also sickle cell population. We're getting fabulous results with the use of the sub-anesthetic ketamine. We do sub-anesthetic infusions that usually start in the recovery room, and in certain populations the infusions start on the regular unit. But the patients are getting relief, as opposed to if we were not using the ketamine as an adjunct, the patient may have more difficulty becoming comfortable.
We are very customer-centric because patient care is a priority. Patient care is number one to us, and we want to make patients be very comfortable during their visit here.
The way my job as an acute pain management nurse makes a difference to patients is that we're there. They can count on us being there when they have a pain problem, as opposed to their nurse possibly being busy with someone else and them having to wait for pain management. We are here around the clock when patients have a large amount of pain. We reassure them that we will not leave them until we give them some relief.
All right, well, now it's time that we hear from you. As we mentioned at the start of the program, our phone lines are open to hear your comments and questions. Our toll-free number is 800-565-8107. Please give us only your first name and the city from which you are making the call. Also, you can email us your questions at vhatvlive@vha.com. So if there's something on your mind that you want to share with us, now is definitely the time for you to get online or give us a call. All right, we're going to answer some of those questions that we have already received. Is everybody ready? Okay. Given recent approval, where does IV acetaminophen fit into your current strategies compared to other formulations of acetaminophen?
Well, let me just take a first shot on that. Now, you remember that when I presented during my presentations on the stepwise ladder, and I would use it the way that I presented. So as a step one, you remember that the drugs are acetaminophen, non-steroidal, and COX-2, and that is where I would use it. And then if there are more painful procedures, always consider the drugs in step one, and beyond that, add other analgesics. So in fact, acetaminophen should be considered in every patient undergoing perioperative surgery.
Yeah. I think a key corollary to that is that it's the around-the-clock use of IV acetaminophen that is so important. And if I cannot miss a dose when the patient isn't able to tolerate swallowing pills, then I can maintain that. Another point is that IV acetaminophen gives very rapid plasma levels, and the efficacy of the drug is dependent upon those rapid plasma levels. So I think the key is not necessarily to replace oral, but to use it to maintain that around-the-clock dosing.
All right, thank you. Deb, you have any thoughts on that?
I would totally agree, and I think one of the challenges is folks are used to using oral Tylenol in a dose of 650 milligrams, but really the effective dose is a gram. And so when we look at using IV acetaminophen, we really need to get into people's mind that a gram is the appropriate dose that we should be using, and like Jean mentioned, around-the-clock dosing.
All right. Next question. The FDA has recently been concerned about liver toxicity and the overdose of acetaminophen. So does this impact your decisions using acetaminophen in the preoperative setting?
That's a really important point. The key issue is maintaining under the 4-gram maximum dose for the day. So the FDA's concern was really with these combination agents, some that contained a relatively high amount of acetaminophen, or where the labeling may not have been completely clear for the patient to understand, where they could take maybe oxycodone with acetaminophen and hydrocodone with acetaminophen, thereby getting over that limit. But if you stay within the 4 grams, the drug is quite well tolerated. And I mean, I guess my only considerations would be chronic liver disease, significant hepatic issues, where you would need to consider the pros and cons. But particularly with the emergence of IV acetaminophen, this is a hospital-based drug where we tend to monitor more closely. And I think as long as the takeaway message is keep tally to keep below the 4-gram dose, and there really should not be an issue.
Okay. Anyone else?
And I think one of the strategies that hospitals can use is if they can implement or embed into their electronic EMR system a cumulative total daily dose of acetaminophen that patients are receiving, then you minimize, say, by accident, people receiving more than the 4-gram total dose.
Deb, one of the things at Thomas Jefferson that we're moving toward eliminating the combination agents. So oxycodone IR instead of Percocet. Acetaminophen is a standalone. So it makes it easier from the pharmacist's perspective. Do you see that as a trend?
I totally agree, and I think that goes back to many drug products that we look back. We used to use single agent modality, and then it became commonplace to use combination therapies of commercial products. But I think to really know where you're at with the product, you should be actually using the individual ingredients themselves and then adding each individual drug to the protocol.
I think both of you brings a very good point, because often When you ask patients how many, what is the dose of the drugs they take, they often don't know. I take 2, I take 3, but they don't know what is exactly in that tablets that they take. So I think separating out, I think that will go a long way in trying to avoid some of these problems.
Okay, let's move on to the next one. This is for you, TJ. Is acupuncture effective for pain management?
Yeah, it's interesting because we didn't have time to cover it, but certainly I think one thing not to forget about, there are some non-drug options. I think acupuncture has been shown in many studies to be as an effective adjunct for acute post-operative pain. There have been many studies. We did a meta-analysis, which is actually in your workbook, that shows that acupuncture not only reduces pain post-operatively up to 72 hours after surgery, but it significantly reduced some of the opiate-related side effects, nausea, vomiting, pruritus, dizziness. And so again, acupuncture in this setting, I think is certainly very helpful. And you don't need to know all the acupuncture points. There are only 2 or 3 points that are important for managing post-operative pain.
Okay, we are tight on time. I'm going to get to another question, but just if you'll keep that in mind. What is your most common multimodal approach?
Well, what I usually do is this. Again, as we talked about the step ladder, first of all to consider is the acetaminophen, non-steroidal in patients that have no contraindications. And beyond that, again, I look at the individual patients who have issue with chronic pain or any use of opioid preoperatively. Adding some of these other agents, ketamine is an important one we talked about, pregabalin, gabapentin are important, lidocaine, local anesthetic, very important. It should be incorporated to think about in all sorts of surgery. So a variety of different techniques, nerve blocks that we talked about, are all very important. And again, discuss with the patient's individualized pain therapy.
Mine is a little simpler. Preoperatively, acetaminophen, pregabalin, and either an NSAID or a COX-2 inhibitor. And then we continue that postoperatively while the patient's in the hospital. And then we add the other items. But that's my base. That's where we start.
Okay. And that would be exactly the same as what we do at the University of Michigan also. So.
All right. Well, thank you all very much. It was an interesting hour, to say the least. All right, that's all the time that we do have. I'd like to thank Eugene Viscusi, Deb Wagner, and TJ Gan, as well as the fine folks who appeared on videotape. Thank you very much for being here. We just enjoyed so much what you have to say. And thanks to all of you who took time out of your busy schedules to join us for this broadcast. Now, as a reminder, this program will re-air on Wednesday, March 30th, 2011, from 12:30 to 1:30 p.m. Eastern Time. During the last 15 minutes of the program, we will be taking your phone and email questions for our panelists live. And finally, please take a few minutes to fill out the evaluation form in front of you. It truly provides us with valuable feedback and allows us to plan for future programs. Again, thanks for watching. For VHA TV, I'm Beth Wilson.